My name is Tito Fojo. I'm a medical oncologist. I work at New York Presbyterian Columbia University in New York City. I actually spent the first 32 years of my oncology career at the National Cancer Institute. And then in August of 2015 decided that I wanted to see what medicine was like in the real world. The NCI is a wonderful place, but it's not the real world. And so my wife and I both moved to Columbia University in New York. I've had an interest in cancer since medical school. I thought it would be the discipline that would change the most in my life and keep me interested and exciting throughout it. I began with treating patients with a broad range of cancers, and not long after that, increasingly focused on more rare and the majority of them endocrine-related cancers, and that's how I came to treat patients with pheochromocytoma and paraganglioma. One thing which is important if you think about this is that these are tumors that come in two varieties, if you will. They can be benign, meaning that they're not cancer-like, or they can be malignant, meaning that they're cancer-like. And it's important to know this because oftentimes you go to read, be it for us medical doctors in the literature, but for a patient who might be looking in the internet, and at times it's not clear if they're talking about a benign tumor or a malignant tumor. And I think our focus today is going to be primarily in those who have malignant or cancers. Just remember, as you're looking for information about this, that there's oftentimes a blending or not clarity as to what you're looking at. Pheochromocytomas are very interesting tumors. They arise in the adrenal gland, which is an endocrine gland, which is located in the back of your abdominal area, and which is a very, very small gland. But it's actually probably the most critical gland in the body. And the central part of this gland, which is called the adrenal cortex, has the cells that are responsible for what we know to be the so-called flight and fright response. You know, when something happens to you and you're scared, all of a sudden you feel your heart pounding and you feel your energy just all of a sudden rise. That's because the adrenal gland, this central part of the adrenal gland, otherwise known as the medulla, is producing these hormones that help you to avoid danger. So tumors can arise from that area of the body, that part of the gland, the central or medulla part of the gland, and these tumors are called pheochromocytoma. And as you might expect, they're interesting because in many ways, in the majority of patients, as they grow, they retain some of those properties of the adrenal medulla, and those properties that were beneficial for us in terms of avoiding danger can actually become quite harmful to us if it's a property that we're constantly feeling or experiencing this. The paraganglioma are related, but arise not in the medulla itself, although they can, but arise in the ganglia of the body, or in the paraganglia. And these are structures that are distributed throughout the body, including in the neck, the chest, and even in the abdomen. And so they're close cousins, but they're arising from different origins, and they have, at the end of the day, a very similar cell of origin, and they share a lot of properties. The paragangliomas, like the pheochromocytomas, can also make these hormones of a different variety, but also hormones that can give symptoms that are sometimes very unpleasant to a patient. Now, all of these things, as I say, can happen with benign tumors. With malignant tumors, they often happen in more catastrophic or difficult ways. The percentage of these tumors that are genetically linked is actually a work in progress, we should say. Years ago, we would have said hardly any. And now we think that the numbers are probably 30 to 50 or even somewhat higher. Increasingly, we're finding genetic causes for these tumors. Now, one of the most frequent ones that I'm sure we'll come back to and talk some more are tumors that arise because of a mutation in a family of genes called the succinyl dehydrogenase genes, or the SDH genes. But there are other diseases. One of the most commonly recognized is a disease called VHL, or von Hippel-Lindau syndrome, that can also give rise to these tumors. There's neurofibromatosis, another illness that can also give rise to these tumors. So increasingly, there's now over 10 genes that can be mutated that we know can cause this disease, pheochromocytoma/paraganglioma. What that number is today is somewhere between 30 to 50%, but in the future it might be more and more. And the other thing related to the genetic causes is that we have genetically caused diseases, but then there's some diseases where there isn't a genetic cause, and by an absence of genetic cause, we mean that there was not something that you inherited from a parent that causes this. There might be a genetic cause for it, but that is happening at the level of the tumor and not at the level of the patient's inherited DNA. So those two are causes of pheochromocytoma and paraganglioma. The SDHB mutation is currently the most prevalent mutation that is found in individuals who have an inherited form of the disease. Now, if you have an SDHB mutation in you, in your DNA, you most likely inherited that from one of your parents, from your mother or your father. There's an occasional case, even today, where we find a patient that has such a mutation that is part of their DNA, but we can't track it to a parent, and we call that a founder mutation. At some point, these things can begin in any individual. But the majority of patients that we see with this disease actually have somebody in the family that has passed on this mutation to them. Now, when you acquire these mutations, you are at risk of developing pheochromocytoma and paraganglioma. That doesn't mean that you will develop the malignant or the cancerous form, but you can develop the benign form. As to what are the chances that you will get it, the correct answer is we don't know, because there's a lot of patients out there with these mutations that either do not develop the tumors or have the benign tumors and either have no symptoms or have symptoms that they've had all their lives and just become accustomed to them. So often you hear the story of the individual who comes from a small town somewhere, and they've been the man or the woman in town who was always jittery and anxious and all of these things. And they could have been like that the rest of their lives, have died of something and never had a diagnosis. So we really don't know what we call the denominator. We only know that in those patients in whom we know that the mutation exists, there is probably a high likelihood that you will develop the disease and a not unreasonable chance, like maybe even 30 to 40%, that you will develop a cancerous type of tumor. I would say that those are the high numbers because, as I say, we don't know about all of those that have such a mutation but never develop clinical symptoms from them, either because the tumor didn't cause them or because they never developed a tumor. So that too is a work in progress. I, as an oncologist, see the majority of patients who have these tumors to have the malignant form, to have a cancer. What is concerning is that those that have a mutation in the SDHB and develop a tumor, number one, they're more likely to develop the tumor. And number two, it's more likely that that tumor will be cancerous. Number three, we also know that when these patients develop a cancerous tumor, they seem to have a greater propensity, a greater chance of developing spread of this tumor to other parts of the body. Now, this should not be taken by anyone who has a mutation as something that they should be thinking nothing can be done. A lot can be done. And you just need to be aware, if you have this mutation, that you need to be careful about yourself and careful about your health care, and also diligent in pursuing continuing health care. Whether or not things happen, that is something that, as of yet, we can't predict. I think we will at some point be able to predict it. When we do that, then we'll take some uncertainty out of the equation. But until that day comes, the best defense, shall we say, for this problem is to be very proactive and to take good care of yourself and have regular checkups. If you're a patient and you have a tumor, and let's talk about a patient who has an SDHB mutation and has developed a tumor, and if the tumor is cancerous, what are the treatment options? So always at the beginning, we try to get the patient to surgery. Surgery remains the only one of our treatment options that can cure a patient. Now, you need to be mindful that we perform surgery, we remove that tumor, we hope that you will be cured, but again, because you have this mutation, you have to be watchful throughout the rest of your life. Now, if surgery is not a possibility, we then turn to other options that we have. And one of them is chemotherapy. We frequently use a combination that many of you may encounter as you go through your research on this problem. And it's called CVD because it's a combination of 3 drugs, C for Cytoxan, V for vincristine, and D for dacarbazine. It was actually developed at the NCI about 30 years ago by one of our fellows at the time, Steve Averbrook. And it has worked very well. Does it cure patients? No. But what it sometimes can do, and often does, is number one, it reduces the amount of tumor and in effect sets the clock back on the patient. And in other cases, is able to take a patient who has a tumor that can't be surgically resected and get them to the point where a surgeon is now able to go in and do the resection. That has value. But the important thing to know is that it is one thing that we use, but that there are other things that we use. And the other important thing to know is that for many patients with tumors of this nature, the tumor is not necessarily going to progress very rapidly. In such a patient, any therapy that can reduce the tumor burden can reset that clock, and it can be a very slow growing clock, and you can derive a lot of benefit from a treatment that maybe was not able to eradicate it altogether, but is able to importantly reduce the amount of tumor. We have other things at our disposal. We frequently turn to our radiation therapist colleagues to treat these tumors with radiation therapy, especially if they're in difficult places that can't be removed surgically. And then as you go through the information about this tumor, you'll find references to something called MIBG therapy. And MIBG stands for methiotabenzguanine, which is a precursor of what these tumors sometimes make, these hormones that cause patients to have the symptoms that they do. And these tumors like to take up these precursors. It's been possible to actually tag these precursors with radioactivity and in effect deliver radioactivity very precisely to those tumors. It's a way to treat with radioactivity, directing the radioactivity to where the tumor is and where you think it might be more helpful. These are current options that are well proven to be of value. There's many things that are being studied, and I would say that at any point in the future, 1, 2, 3 years from now, these options will still be there, but we'll have other possibilities added to that as well. Where do we see treatment for this disease going? And I think that I personally am quite optimistic. I think that for 2 reasons. Number one, that we increasingly understand the disease, and the SDHB specifically has given us an enormous amount of insight into this disease and has identified, I think, points that are possible for intervention that would be points that a cancer cell would be vulnerable against. Now, let me caution you that I don't think we're at the doorstep of a cure for this disease, but I think we are opening the door to more better therapies and more options that can meaningfully prolong a patient's life. Now, I think there's 2 things, actually 3 things that one can think about in terms of this disease. Number one is it still remains a very peculiar and uniquely peculiar disease that has certain attributes, certain properties, certain characteristics that no other tumor has. And our task is to exploit that in very precise ways. And so, for example, the MIBG is one such example. They have this ability to take up this radioactivity that other tumors generally cannot. There's a couple of other instances in children. A disease called neuroblastoma is similar to pheochromocytoma paraganglioma, and it too can take up this radioactivity. So I think we now know a lot about the specifics of the disease, and we should be able to, with the knowledge that we have, target these points in the disease that we think would make it more effective in its treatment. The other thing, then the second level, is that we recognize this to also be in the general category of a neuroendocrine tumor. So when you have a rare disease, you try when possible to leverage the knowledge from other cancers to your benefit. And I think that we want to think of ourselves, and that by that I mean ourselves as the researchers that work on pheochromocytoma and paraganglioma, as also working in the general domain of neuroendocrine tumors. The reason that's important, it's because a lot of research is happening in neuroendocrine tumors that we want to see what applies to our tumor per se. Not everything applies, but some things clearly do. There's currently a lot of interest in other receptors that are expressed on these tumors and neuroendocrine tumors, the so-called somatostatin receptors. I think we'll come to understand that better and how we can derive the knowledge in neuroendocrine tumors to benefit patients with pheochromocytoma and paraganglioma. And then there's the third level where you look to other cancers for clues. And it's there that you might, with some luck, find something that will be of value for this disease. We know that a lot of things are being developed for other cancers. We have to understand how they work on those cancers and then pivot to our diseases of interest and ask, could that potentially work in our disease? We don't want to try everything that's being tried in breast cancer, colorectal cancer, lung cancer. Many of them have no relevance to this disease. But if something works in those diseases, if something has been developed in those diseases, that might potentially be a benefit for our diseases of interest, then we have to take those and pivot them over to our disease and try to see how we can use them. So if you're newly diagnosed with pheochromocytoma or a paraganglioma, I would tell you two things. And I think it's the message that I always try to give patients. And it's one of careful follow-up, measured, mixed in with very cautious optimism. But I think that the future looks bright. The first thing that you need to know is that in a majority of patients with this disease, you've actually been diagnosed with a cancer that you're going to live with for a long time. So the first thing is, don't panic. Number two is, and not because I deal in this disease, it is good if you find somebody who does this for a living. This is a rare disease. Actually, benign pheochromocytomas is what every medical student learns about in medical school and says, someday I'm going to discover that. And then they look for it 100 times and they give up on it. And then the day that it walks in their door, they miss it. And it's interesting how many patients come and they were screaming, I have pheochromocytoma, and it was missed because we searched for it 100 times and said, oh, this really doesn't occur. It really is rare. So find someone who deals in this disease. And then have a plan that is one for a long term. You're in a marathon with this disease. You needn't be thinking, I need to do something by tomorrow. And it's also why you seek out other opinions, because you have time to do that. Get your symptoms controlled if that's what brought you to the attention of the physician or the oncologist, but then be diligent in your search and be thoughtful about what you're going to do. Then continue with follow-up. And the truth is, I am hopeful because I think we understand a lot more today, and I think we'll be able to convert that into better therapies for patients. And I'm also hopeful that those better therapies are going to prolong the life of someone who already was going to live for very long. The moment you do that, the moment you have a cancer that you're going to live with for a long time, that we can potentially prolong for an even longer time, is when then I can't tell you what you'll be treated with 10, 20, or 30 years from now. I don't know what the future holds. I just know that it holds a lot of promise and a lot of new possibilities. And so consequently, just go about it in a very thoughtful and diligent way and remain with very cautious optimism. An important issue that occurs with patients that have a genetic cause for their disease, and the most frequently arises in the context of individuals who have an SDH mutation, and that often most frequently SDHB mutation. And you have the diagnosis, and then now what do you do with that information? Especially if it has been something that you have inherited, there's a lot of people above and beyond you that may have it. So if you've inherited this mutation, it's probable, as we have discussed, that it came from either your mother or your father. And you need to find that out. And usually the mom and the dad want to participate in that process. Once you have that information, then you have to ask yourself, who else should know this information? And I think it's important that you share that information. What happens with that, we'll discuss in a second, varies depending on individuals. But if you have such mutation, and if it came from one of your parents, then realize that any brothers or sisters that you have may have that mutation. And then if you're an adult, then there's a third situation that you have to consider, that some of your children or some of the children of your brothers or sisters may have that as well. So it's important to get this information, give it to those that might be impacted by it, and what they do with that information varies. There's increasingly a strong push on the part of an oncologist to refer a patient to a genetic counselor, because we believe very strongly that the more information that you can share and the more people that become aware of it, the more important that becomes. And it's important because for this disease, early diagnosis can make an enormous difference. If my sister had that mutation, I would want to know it so that I could then be followed properly. And if I develop something, that an early surgical intervention can be instituted, and that I'm most likely to be then cured of this disease. So remember, when you have that, then to think who else should know about this. As regards what you do when you have that information, and what if you then have the mutation, that comes to follow-up. And a question that often then comes is, how often do I need to be followed? How often does it have to be? With what modality? In children, which is something parents worry a lot about, we follow them oftentimes at an interval of 2 years. We use MRIs to avoid the radiation exposure so that we don't have to be worrying that we're exposing them to radiation at an early age. And so this, what you should interpret as, is that we're concerned, but we also recognize that this is a slow-growing disease, and we have to put it in context. Adults, we sometimes use MRI, but we also are more freely or more likely to use CT scans that exposes you to radiation. I always tell patients, if we're doing that, it is for a reason, and we've determined that the value of that, the gain that we're going to have from that, far outweighs any risk from the radiation. And then just keep that in mind. If you have that diagnosis, think about who else needs to know about this, and by all means share that information. You yourself should seek out genetic counseling, and then try to bring as many people as in this sphere into the genetic counseling process so that they can make the right decisions. You'll oftentimes find that a relative or a brother or a sister wants to avoid it altogether. They'd rather not know about it. This is a situation where information is incredibly valuable to have. And so try to get that individual to also go to a genetic counselor so that they can make the right decision. If you have had a genetic cause identified for your disease, and you yourself or other people that are related to you, brothers, sisters, your children or your parents, are going to have genetic testing or desire to have genetic testing, they need to see a genetic counselor. And then actually, it's a very simple test to do. All you need is a blood draw. And nearly all of us have had a blood draw in our lives. What's more difficult is where to get it done. And there are currently very few places that are certified, if you will, to do this. I think in the future there'll be more and more opportunities will be available. And then the other concern is that this costs money. Sometimes, and increasingly so, insurance companies are paying for this, and that's good. I think they recognize that it's valuable for them to know as much as possible about the individual to whom they are providing insurance and health coverage. Hopefully that'll become more broad in the future. But if it's not, it can sometimes be a substantial amount of money. And it's in those situations that then more difficult decisions come into play. There are organizations that can help with this and that can provide money, because we think it really important that you be tested so that you know whether or not you need to be concerned and whether or not you need to have follow-up.